professions in terms of the funding stream. So I think that there is the real advantage, perhaps with some of the national mapping and working, that the funding becomes much more widely used. I don't know whether that's...
Yeah, I'd completely agree with that, but I think there are also different models of using and distributing simulation, which perhaps also have a very different funding model or requirement on that level of investment. And I think, you know, that there have been examples of, I think London would be a very good one, where there's been significant investment, but on a distributed model.
Yeah.
And actually, I think that has probably spoken to trying to broaden access and develop capabilities to make best use of simulation at a local level, whilst also accepting that some perhaps more regional facilities might be available for specific things which are perhaps a bit more costly. But I think you have to have that integrated model in mind, and I think our responsibility of the commissioners as much as us as the workforce.
Okay, thank you.
Thank you. I'm Gordon Caldwell, clinical tutor at Worthing. Rob, I just want to say fabulous talk. Thank you. Tremendous to see how you developed all that work. I've been thinking that perhaps we should use a new word, teamsmanship, for the team members, which is to do, instead of just having leaders and followers, teamsmanship and the role of the teamsman and what's the responsibility to the team. I think that's a very helpful concept. The bit about deconstructing the hierarchy, hugely important. I do that very actively in my team. On Monday, I went up to a patient and said, so you've been in hospital with pneumonia and atrial fibrillation for 5 days, and the F1 said, no, that's the diagnosis for the next patient. So to have your junior doctors there willing and ready to interrupt when you're making a mistake and to dig you out of the hole, tremendously important. And finally, the last thing we've been trying in the last 9 months on all our ward rounds is that the person who writes the note sums up at the end of the consultation. So instead of me saying, you've been in for 6 weeks with SBE and you're going home, it's the person who's written the note who signs it up, who sums up. And that gives them a role. They have to listen. They have to be able to do succinct synthesis, précis, and it makes sure that the whole team understands what's going on. It's really powerful. And often whilst they're summing up, something else just comes to mind. But great talk. Thank you.
Will you ask a question?
No.
Oh, sorry. But just for that, I think it shows that in non-acute situations like ward rounds, the human factor is so important. I remember as an F1 going down to radiology, asking for scans and just saying, because my consultant surgeon wanted them, without any understanding of why. And that is no way to learn. But by bringing human factors into the ward round, not only are you improving the care you deliver, but also improving the education. So I think it's not about, I talked about the acute sector because that's where I feel comfortable. It's equally applicable on the ward rounds and the less acute, and also outside of the hospital setting.
Thanks, Rob. I think Ian's got the microphone, or sorry. Just do 1 and 2, that would be great.
Hello, I'm Mary Rose Shears, Associate Dean for General Practice, East Sussex. Thank you very much for your talks. And I've got a question for Rebecca Burden. Stimulated by the other talks and conversations, obviously in general practice we are very interested in human factors, soft skills. And we have a model at the moment that everyone, all the staff, all the doctors have to have basic life skills training once a year, every 18 months. And as Rob says, it's very much based on the individual. So we have a go at doing the mannequin, we sit in and listen to the talk, but we don't really think about as a team how we're going to do work together in an emergency. And it's quite rare in general practice, but when it does happen, it happens in the car park, it happens in the waiting room, and it really matters we deal well with it. So I was just wondering if you've got plans to take your ambulance round to the community and how that will work.
It's a good it's a good question. I think the idea behind the ambulance has been very much about the areas sort of associated with acute hospitals that I talked about in the first place. However, it's not beyond being able to actually take it into community care. The idea of the ambulance is it's accessible to all healthcare professionals. But just to add on, there is another project that we looked at last year, which we didn't move forward in this year, that we will be looking at next year, which is about a mobile SIMS unit, particularly for primary care and community care. And that would probably address the issue that you're actually talking about, because it would actually take a smaller unit out to GP practices and the more remote community providers with a trained simulation trainer to actually carry out those sort of sessions.
Thanks, Rebecca. I think, Ian, have you got the...
Ian Curran, I've had the privilege of running the simulation program in London for 6 years, and one of the things that we found very beneficial was aligning it to care pathways and service pathways. So, for instance, the trauma service, we commissioned trauma team member training and trauma team leader training, and they were provided for whichever professional groups needed that training. And it does move the focus of commissioning away from uni-professional onto service and workforce development, which I think is critical. I think the other point would be patient safety is clearly necessary but not sufficient. And I think the other piece is about aiming for excellence, and human factors is about optimizing human performance. So it's not just about ensuring safe minimum standards, it's about pushing people on to be as good as they possibly can be. And I think that notion of excellence is central to it as well. The National Quality Board, before Christmas, published the National Concordat on human factors in healthcare, which was an undertaking of all the arm's length bodies to promote human factors. And clearly there's going to be a lot of work done around that going forward. And one of particular interest related to the question mentioned earlier was the National Primary Care Quality Improvement Project, which is going to be based on human factors, and that's led by Mike Berwick. So I think there will be human factors for the primary care and community settings going forward. So it's wonderful to see this very innovative and progressive meeting. I suppose my challenge would be, what do you see as the main barriers to this more widespread adoption within your KSSS locality?
You directing that to Philippa or?
Well, Philippa for a start.
I suppose most of the last year has been about trying to understand what we've got. So I think there's, as Rebecca and others have said, there's been a lot of good work across the 3 counties, but it's really understanding what that is, how we can either roll it out quickly. So we invited Rob and the team to present when we had Ian Cumming come to visit, the Chief Exec of HEE, and he recognised that good piece of work, and we've been thinking about how can we roll that out, but also how can we roll other pieces of work out. I think one of the barriers I'm hoping has gone in terms of the pockets of funding, because that seemed to be a real issue when we were going around. It didn't matter who you were from the organisation, go out and talk to our providers, and they would say, yes, that's great, but you give me this 50p for this and this pound for that, and I'm not allowed to use it for this or not use it for that. So we're hoping through the new kind of integrated, I guess, contract and supported by money, because everything follows money, doesn't it, that we will have addressed a lot of those barriers. But what we've tried to do through sort of Rebecca's work and sort of led by Abdul as well is to just also not rush out and throw money at the first thing that everybody thinks is a great idea. It's about trying to say, we've still got a finite amount of money, where can we get the best leverage or move the quickest forward across the 3 counties. So I think we've got rid of one of the big barriers, or I hope we have. Time will, next few months will tell in terms of funding. Then I think the next thing is about being clear through having really robust kind of program management. So there is a stakeholder program board that Rebecca described, and that's really important, because that's the way that we know what's happening, or we're starting to know what's happening, and then make the decisions to roll it out. And I suppose the final thing I would say is sustainability, because we all can identify areas where we've put money somewhere. We've started it over here, we started it over there, and then what happens is nobody's around, or the system changes, or something else happens that's beyond your control, and everybody remembers that good idea someone had once. We're trying not to do that. We're trying to make sure that what we do put in, we can, is sustainable and will go forward. So does that answer that question?
Thanks, Phil.
I just want to add something, or perhaps ask a question. I was I'm on film. I was trying to get away with half an hour of not upsetting people. So I don't know. One of the things that we're picking up nationally, which is a significant barrier, is just releasing people for time, either to attend and take part in educational activities, which are workplace related, system improvement related, or to help develop and support the faculty, the educators, to really drive it forward. And I think that it's a fundamental barrier, and I'm still not sure where, from the employer's perspective, they really sit on this, because I think we hear words that are very supportive, but the behaviours we see are quite different. And I'm just a bit worried about that gap at the moment. I don't know what that's like across your region, but that's a question.
Well, I was just going to add to that. That was a topic that we discussed at the board development day a couple of weeks ago on sort of patient safety and what do you look at. And it was exactly that. We would say, what's the workforce information that you're looking at? And what do Monitor measure? What does CQC measure? Who's measuring what? And does anybody measure the training that you intended to do across your organisation, that you planned, that came from people's appraisals, personal development plans, your own strategy, and then what you actually managed to deliver at the end of the year? And is there any correlation between, kind of the missed training that you identified and then outcomes for the trust, patients, obviously, and some of the other quality indicators that we might look at? And the range of people at that event did not look at that. And I don't know whether that is something that that we should be encouraging people to do, because we are putting funding out there through a number of streams, and you're absolutely right. The biggest challenge that we have come back to us is, but I can't go, or our universities will tell us that they had courses planned and at the last minute they have, 3 people turn up as opposed to 20 people turn up. But I suppose for me it's the bit around helping boards look at what is the workforce information you're looking at, whether it's your vacancies, but more importantly, it's that training. If you've identified it and you're saying people need it, for to develop their skills or to provide safe services, and then it doesn't happen, where does that sit? So
I think that almost takes us into a wider discussion, which is very much about how you develop the learning organisation, which is an integrated approach, and that the board is really clear about some of the issues that are coming up and through. And I know we have a couple of chief execs here in terms of networking and discussion later, but I think those sorts of conversations are much more about how you tie the whole thing together. I'm just going to go to the person over there who's very patiently waited for some time to ask the question.
Thank you very much. My name is Jo Lawrence from the Brighton Sussex Medical School, and I'm directing my question to Rob. I'd like to thank all the speakers for their presentations, which were very informative and very stimulating, and I felt linked very nicely with each other. My question really concerns, I suppose, to all of you. Is it, with the number of trainings that currently exist, national trainings, do you feel, Rob, that we're putting enough energy into evolving those trainings so that we are learning the lessons from the past? And I would say the example that you made reference to, the Resus Council, we have new guidelines coming up next year. Do you think we're putting enough energy into existing systems that are already nationally out there to perhaps evolve them so that human factors are taught more substantially within those? Because it seems crazy if we have that system that is nationally and recognised for all doctors to do for revalidation, that we're not enhancing that and having more proactive input into what will form the new guidelines and the new courses as of late next year.
I completely agree. And one of the things, we've got an amazing faculty of resuscitation trainers and resuscitation officers. And in our trust, they're not actually coming under the education umbrella. They're stepping outside of it. And to me, that's the type of people who are the perfect example of who could be pushing human factors. And so, yes, we need to work within our existing structures and say that Research Council, there is a move towards it. But on ALS courses, on ATLS courses, everybody is the team leader. You don't learn how to be that followership or the team membership. and that's what we need to work towards. But I think there's also a broader way of how we can push it. Human factors simulation is not embedded into what we do on a day-to-day practice. So we need actually to be routine. So we're doing, for every 5 patients we're seeing in the emergency room, we should have a simulated patient. And we try to do it, we often do it at night time when we've got time when there's no patients. But just in terms of the cultural problems we've got, we had our simulator, thank you very much, which we had we paid for it, which we had in the emergency department. Which had it in the emergency department. We're doing a simulation because there was no patient. It was 4 in the morning on Sunday night because there's no patients waiting to be seen, and we're doing some scenarios. And then a couple of patients with very minor injuries came along. They'd been waiting 15 minutes, and the site manager came down and said, "Do you not think you should stop that to start seeing the patients who are waiting?" And so we need to change the culture of actually human factors need to be embedded. We need to be able to be in a situation where whatever we're doing is being videoed, and we can then take 10 minutes out for each patient we see to look back at what we do, then go and see them up on the ward and actually follow them up, see the impact of what we do. It's about changing our existing structures, but also embedding a different way of educating into clinical practice, as well as making education and clinical practice separate things, because they're not.
Thank you. Thanks, Rob. In fact, I'm going to finish there because it takes us to the allotted time, and thank the panel and the speakers, and it has been truly informative, so thank you. And you will get an opportunity, obviously, to network with them over lunch. Thanks very much. Who's our last speaker?
Yep.
Who is it? Nick Lewis. Really pleased to end this first session with a slightly different focus. I'm going to introduce, we haven't actually met. I'm going to say hello. I'm Nick. Hello. Nick Lewis Barnett, who's a clinical fellow at the Royal Colleges, and is going to talk to us about shared decision making. Thank you.
Thank you very much. And thank you very much for getting my name right. Usually people don't, so that's really nice for me. A little bit of, first of all, thank you very much for inviting me. I'm here with an RCP hat on, and I've got, I think, my full title is the Clinical Fellow for Shared Decision Making and Support for Self-Management, which gives me the longest title in the college, and that makes me very, very important. In my day job, I'm an endocrinologist and diabetes physician, and one or two of the examples I'm going to use reflect what's my experience, but I think you'll be able to translate them fairly easily to your own. And I'm conscious that we've had a kind of very health professional-centric morning so far, so I'm going to try and be the tail that makes the dog wag a little bit if I can. So what's it all about? And what I would like to talk about is thinking first about what the problem is. Is there a problem? How are we getting on with it? Because there is some evidence around this, and the evidence is not necessarily what we expect. What do we mean? Because some of the terminology is a bit difficult. What support is there? Why support? What support is there at the moment, and why is this a good moment? Why is there a problem at all? And I think that's not always obvious to us to start with. And then what can you, by which I mean Health Education England, HEKSS, do you call yourselves HEKSS? No. Oh, okay, we'll try not to do that. Apologies to the new chief executive. But what can we as individuals and organisations be doing? So first of all, what's the problem? And the problem, or opportunity depending on your perspective, is Premony. Premony actually is somebody I know. She's about 65 years old. She has had type 2 diabetes for 6 years, bit overweight, a few other medical problems. I won't even go through the list of drugs, but when you're taking the list from a GP and A&E, there's lots of opportunity for error here. Glucose control, I think, would be on the next step of your local stepped approach to increasing the drug treatment. Cholesterol's a bit high, EGFR's kind of all right. So, stand back from that, get people to think a bit. I'm going to do a quick quiz with you. You don't have to shout out the answers, and no one's going to record your scores. But I am going to ask you to do what we call a Roman thumbs approach to this, which is if you think the answer is yes, stick your thumb up. If you think the answer is no, stick your thumb down. And if you're not sure, stick it in the middle. and I'm going to just keep a bit of an eye out for how people are doing generally. Is that okay? So my first question is, do our patients feel satisfied with the care that they get? What do you think? Okay. It's quite a lot of ambivalence, a few negatives, but actually when you survey patients, they are quite satisfied, actually. My second question is, do they respect and value healthcare professionals? Yeah, they do, actually. They just love us. A little bit more tricky. Do they have the relevant information about their healthcare? Yeah, there's lots of down. Yeah, if you go round, some of the time they do and some of the time they don't. What about patients feeling listened to and involved? Yeah, some of you have had some experience of being patients, clearly. Okay, right. What about doing what they're told? Okay, no. Well, actually the evidence is it doesn't depend on their age very much. My mother lives 5 miles from here, and we can tell you about her doing what she's told. She's in her mid-80s. She just doesn't. About anything, actually. How about taking tablets as prescribed? Yeah, okay, we've all got that one. What about outcomes as good as they are described in the randomized control trials? No, absolutely not. So we've got a problem. And I'm using diabetes generically here because Premley's got other things going on too. But these conditions are complex, they're dangerous, they're risky. We have treatments that make a difference, but patients don't do it. So there's a problem. I'd like to know why you think that is. So if you can just shout out, for the sake of the camera, I'll repeat what people have said, but just shout out why you think that's the case. They're not listened to. They don't understand. Yeah. Anything else? Yeah, they feel like children. Yeah. And did I, as a child, do what my parents said? Interesting one. Yeah. Who's in control? So lots of good reasons. Okay. So how are we doing? When we present stuff around working with patients, everywhere we go, and my background to this was working with a program that some of you may have heard of called the Year of Care program, and I was the clinical lead for the pilot program in the Northeast. When we go around, people say, but I do this stuff with my patients all the time. So let's just have a look at how we do. This is international figures, so this is in general. Do doctors always tell patients about the treatment options and involve them? And do they give patients a plan to manage their care at home? This is an international survey, and the UK is over here on the right-hand side. So we, in terms of always telling people about stuff, we're better than France. I don't know whether that's good or bad, and if you're French, you might not like me saying that. And in terms of giving people a written plan, we're better than France and Germany. Well, is that right? France and Germany? Yeah, that's about it, really. Okay. The Americans are better than us, and that's extremely upsetting to many of us. If we think about hospital, lots of time in hospital. Patients are rather bored in hospital. In fact, they have lots of opportunity to learn about things and get more involved in their decisions consistently. Now, the numbers go up to 2011 now. They're exactly the same. For the last 15 years, patients have not been involved in decisions about them in hospital for more than half of the time. What about in primary care? This is diabetes. So these are patients with diabetes. In the Healthcare Commission's report in 2007, we have become very, 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 very good at seeing patients at least once every 15 months. Quaff is a word that people will recognize, okay? So we're good at seeing them. More than 90% of patients are seen every year by their GP in a structured way, more or less. But when you ask patients whether they've had the opportunity to discuss ideas about the best way to manage their diabetes, or agree a plan to manage it, or discuss their goals, it's happening less than half of the time. So wherever we look in the health system, clinical competence and patient engagement are disconnected. And that leads us to a dilemma in terms of making decisions with patients. because we are unaware of the patient's circumstances and preferences, and they are unaware of the clinical evidence. And so when we put those together, we make bad decisions. Does that make sense? Or to put it another way, I'll let you read this. Okay? So we're in this really, really difficult situation that we've acculturated ourselves to a way of working that's rather unhelpful. Thank you for the pre-quote. Okay. Rita Mae Brown, Insanity, is doing the same thing over and over again, expecting different results. But with his usual subtlety, Einstein urges us just to develop some new thinking around this. All right? So we need to think differently. So what are they? What are these things, this shared decision-making and support for self-management stuff? And the first thing is this comes with a government health warning, because everywhere you look, there's a different piece of language that describes it. And somebody pointed out to me the other day, there's an important one missing, but you know, I've forgotten what it is. All right? So there's all this language around it that's quite confusing. Some people think it's one thing, some people think it's another. I heard shared decision-making being used a moment ago to reflect the decision that we as professionals make in a multi-professional way amongst ourselves. We then share it with the patient. Okay? That's not what we're talking about, guys. It is really important to make those decisions, but it's not what I'm talking about. And when we thought about the relationship, particularly between shared decision-making, I only want you to think, to remember 3 bits of terminology. One is shared decision-making. The second is support for self-management. I'll come to care planning in a minute, because that's also a confusing bit of terminology. But shared decisions are really about events. There's a choice. Someone can do one thing, or they can do another. I can opt for my hip to be done, or I can opt for some other form of treatment. I can opt for a stent or a bypass graft, or whatever. Those are kind of Boolean decisions that people make, and they're across on that, on your side, the left-hand end. On the right-hand end, as we look at this, there's the planned care that people effect for themselves day to day. We call that support for self-management, and the role that we have in helping people to do that. And that might be delivered by non-traditional providers entirely. So if we look back 20 years, weight management was not a clinical intervention. It was something that people may engage with Weight Watchers or not. But now we have weight management on prescription, okay? So it may be that some of this stuff is not stuff that we're used to offering. I will tell you about the Cod on the Tyne program later if you want, but there are ideas that are out there that we can tap into. This is the patient's perspective on this. We talked about the doctor perspective a moment ago. So after all, when you seek advice from someone, it's certainly not because you want them to give it, you just want them to be in the room while you talk to yourself, okay? And actually, when we think about ourselves, most of us actually make decisions that way. We go around, we bounce them off people, but in the end, we make the decision for ourselves. So we think the key elements of shared decision-making are when patients and clinicians work together, not for one another, but with one another, to select the test treatments and support packages that are based on the clinical evidence, that's what we bring, and the patient preferences, and I put in the bit at the bottom. We give them equal value in the decision. And that means that that diagram I showed you before looks different, because patients bring something into the room, and we bring something into the room. And when we talk about age, that may be more about the fact that the older you are and the more experience you have of the health system, the less you expect anyone to actually ask you what you think. And that needs to change. There is an evidence base for this, and the big macro evidence base comes from a model of chronic care known as the Wagner chronic care model. Health planners will have heard of this, but most clinicians won't. And Ed Wagner is an American health economist who looked at every health system where it can be counted to see what made outcomes better. And what he identified was that you need a bunch of stuff happening out there in the community that gets patients ready to be engaged in the decision. But critically, you also need the health system to activate the professionals to allow them to become involved. Indeed, to look for them to become involved, and that's where you get both your most cost-effective and your most effective outcomes. Just in the middle of all of this, I'm just going to make a bit of a play for long-term conditions, because long-term conditions are different. Some of you may have seen this graphic. This is a graphic that was produced by a patient at a World Cafe event. Could you put your hand up if you've ever been to a World Cafe event? Okay, so there's about 2/3 of you that haven't. In a World Cafe event, we would have put all of you into a room. We would have given you a question. We would have given you paper tablecloths, not because we're cheap, but because we want you to write down your answers on the tablecloth. So the way that you collect in the ideas and thoughts and solutions that people have is to take the tablecloths away, all right? And this was on a tablecloth. We don't know who put it there, but this is someone talking about what it's like to have a long-term condition. Now, you've had a bit of a chance while I've been wittering to have a look at that, and essentially what they're saying is my long-term condition gets better and worse. I don't know whether up is worse or up is better. Along that, I have episodic contacts with healthcare professionals. And the first thing you notice is that the episodic contact has nothing whatsoever to do with whether your condition is better or worse. It just happens every 3 months because 3 months is convenient. Or in my clinic, we're trying to make them 6 months so we can get more people in over time. Okay? So it's unconnected to your illness. And the second thing that became really obvious when we looked at this was that people, if they are frequent flyers, I don't like the term, but if they're frequent flyers in general practice, they may spend 4 hours a year with a health professional. Now, it's 7.5 minutes per consultation. That's once a month or twice a month. That's a lot of visits for a patient. But that patient has spent only 4 hours a year with a health professional, and they've managed their condition for 8,756 hours. In other words, the primary agent in people's care with a long-term condition is the person themselves. It's not us. All right? It's not about us. And so when we began to think about the key to good outcomes, this is the Ed Wagner model. We need the bit in the middle to work really well. In other words, those vertical orange lines need to be much more helpful to the wavy green line than they have been in the past, and we call that care planning. By care planning, I don't mean the piece of paper that a district nurse produces, not a criticism of district nurses, that's worked out in a darkened room with other health professionals and is then done to the patient. Now, that's a parody, I know, of what happens, and I'm going to be crucified at lunchtime. But it's about a collaborative relationship with patients, which results in a document that reflects the plans that are actually going to work for that patient. So it's a process of agreeing a plan. It's a verb. Right. Why is this important just now, and why is there support? So my first question, if someone can shout this out, that's fantastic. This is a health policy statement. The health and social care system must be shaped around the needs of patients, not the other way round, so that step by step over the next 10 years, the NHS will be redesigned to be patient-centred and to offer a personalised service. Can anyone remember where that came from? Anyone? Sorry? No? Yeah, who said that? Fantastic. When was that published? Exactly. So over the next 10 years, by 2010 it will become commonplace. If you believe this is commonplace, put your hand up. Okay. So the aspiration has been there for a long time in policy terms. All right? And we're going to talk about why that hasn't perhaps translated a bit in a moment. That's been reinvented by, I keep calling him the late Andrew Lansley. He's not dead. He's just not currently in power. At least I don't think he's dead. If anyone knows better, you better tell me quickly. I'm going to really be in trouble. But this idea of no decision about you without you, this has been applied largely to where you get your care, but actually it's about all of the decisions. And it's now been built into the NHS mandate, so if you're a commissioner, this is there for you. In Domain 2, we're going to be dramatically better at involving patients in their care to manage and make decisions about their own care and treatment, and it will be coordinated around their choices and the choices of their carers and families. So we've got it there. I'm slightly proud of this, but slightly to my surprise and quicker than I expected it to happen, the College of Physicians adopted this and has taken a position statement. If you want to read it, it'll tell you exactly what you expect it to say, so you might not bother. But it is actually quite a good statement about what we as a college intend to do, and would love other people to do something similar. And then coming out of Francis and Berwick and all of that sort of stuff, the college has published its Future Hospitals Commission report. And again, it's firmly embedded in that, so that as we go forward to designing what hospitals will look like, we want to put this process of partnership working with patients right at the middle. So with all of that marvellous stuff out there, why is there a problem? Okay. So it's a mind the gap moment, and I stole this from the internet, as we all do. It's a microphysics to large-scale structure in the universe stuff, what's in the middle, guys. And what's in the middle is making it practical. When I go around and talk about this, people say, but what does it actually look like? How are we actually going to do it? And I'm going to give you some ideas around that, but there isn't time to go into lots of detail, so please grab me at lunchtime if you want. I'm going to do it by getting you to do something, and I'm going to see if there's a willing victim here. So just for a moment, I want you to think about the last time you made a big decision. Please don't make it too personal or embarrassing, because if I do call you up, you're going to have to say it to everybody. But has someone got something that they've made a decision about recently that they would be prepared to share? Can we give that guy a microphone then? Would that be great? Would that be all right? Okay, so what was it?
Well, I made the decision to buy a mobile phone, a smartphone.
Okay, okay. So how did you go about making that decision? It's buying a smartphone is the decision?
Yeah, can you hear me? No? Yeah. I asked my young daughter first, you know, she's 18. So I said, which mobile phone do you think I should go for? She said, Dad, you should get me an iPhone 5 first, and then you can go for a Windows phone.
Okay.
Yeah.
So the first thing you did you say your granddaughter or your daughter?
My daughter.
Your daughter, oh.
Yeah.
I was just going to say, you really don't look old enough to have a granddaughter of 18. But so you ask someone who you think has some knowledge about it.
Correct, yes,
Okay.
use them, yes.
You didn't quite necessarily expect the degree of personal vested interest, but that might reflect the clinical decisions too.
Yeah.
And she said that you should buy her an iPhone 5 first.
Yes.
Okay, so there's
she
a
can
cost
get both
to it.
contract on that.
Okay.
Then the other thing I did sort of said, yeah, okay, let's have a look. And then what I did was I Googled the stuff, you know. So I went on the internet.
Yep.
And what I did was look at reviews of both iPhone 5, because if I was buying a contract, I needed to know what she was getting.
Yeah.
And how much it was going to cost me.
Yeah.
And also, from my own point of view, when I Google the smartphone thing, I was looking at the different models and also the reviews on whether I should go for an Android phone, for an Apple one, or for thing. So I was, sort of looking at some of the criteria of what I was going to use it for.
Okay.
And what benefits was it going to bring to me.
Okay. So just picking out some of the things in there, you talked to your daughter, but you didn't wholly trust her. You checked it out on the internet.
Yes.
You looked at other types of phones.
Yes.
You looked at the different contracts and how much you'd get for your money.
Yes.
And then you thought, quite late on it seems, about how useful it would be to you and what difference it might make.
Well, I think...
but maybe that was at the start. I'm being very unfair here.
I think the issue really is that I've used other phone before. You know, I've used an Android phone, and I was moving on to buy a new mobile phone, which was a different operating system, which used the Windows operating system. So I had some idea of what I wanted, and I tend to look at something, and rather than sort of jumping in and buying something, I always look at what benefits is it going to bring me. You know, like, for example, I can access my email, my stuff on the move, stuff like that, and make notes and get directions and stuff like that. So I look for the benefits.
Okay. And how long did this process take? Just quickly, how long did it take?
Gosh, it took me a couple of days.
A couple of days. Okay. It took me about 3 months to come to the same decision. Okay. But what's interesting is that looking at it, you made your decision and ended up with an iPhone in a very different way to the way I made my decision, and also ended up with an iPhone. and then was irritated that the iPhone 5S came out 3 weeks later. You know, and so the reality is that even for something as unlife-threatening as a phone, now it might be life-threatening for some people, but we do a lot of work to make a decision. Imagine then how the decisions get made with our patients. All right? Standard process in a diabetes clinic to start insulin. 20-minute consultation, patient comes in, I tell them what their HbA1c is, I lay out their options, I get them to make a decision, they go out of the room clutching a new Novo Pen 4 in one hand, and some advice about how to deal with hypos in the other, okay? Now, that's very different from the way that we make life decisions. But that's a major decision for that person. Normal behavior, another quiz for you all. How many of you always drive below the speed limit? Always drink within recommended safe limits? Oh, that's brilliant, good. There's a few sensible people here. Up to date and fully confident about your life insurance, sickness cover and pensions? Okay. Back up your computer files regularly? My goodness me, there are some exceptional people here. So if you answer yes to all four, probably to any of them, all right? Normal patient behavior, of course, they believe everything we say. They take their tablets correctly. They never cheat on their diet. And they tell us the truth all the time, okay? So in a funny sort of way, when we step into a consulting room or onto a ward round, we begin to treat patients as if they aren't really human beings. And that's part of our problem, and I think that's where the gap is. So what about practical solutions? Going back to Premony, in order to decide about any of the things that are going on in her health, before the consultation starts, she needs stuff that she currently hasn't got. She needs to know more, as somebody said, about why this decision might need to be made at all. I probably shouldn't mention the hospital, but I'll mention it. I came back from New Zealand after 8 years there and sat down in a hospital in Gloucester, and I asked my patients, every single patient successively, why they thought they were there. Less than 1 in 10 patient knew. They were there because I'd asked them to come back, or the previous doctor had asked them to come back. So the purpose of the consultation is unclear to patients a lot of the time. And during the consultation, she needs support to explore and decide, rather as your daughter did with you, about which is the best phone for her. And then she needs some follow-up, just like your contract provider provides for you. I've mapped out here, I haven't mapped out, a mate of mine has mapped out here what we think we do now in our 20 minutes. So a patient comes in, we learn at medical school that diagnosis is really important. So we spend the first 5 minutes of our 20-minute consultation either finding or checking the diagnosis. We decide that something needs to happen. We discuss the options. We work out a plan. We give them a decision. I'm putting it that way. And if they're lucky, they get an information leaflet as they leave the door. Does that result in actions? Well, actually, we know that it doesn't a lot of the time. And we are surprised by that because we know that we're there to do good things for patients. We're hardworking, caring, conscientious people, but actually it doesn't seem to work. What would happen then if before the patient came, they had their own relevant health information in advance with something to support them to understand what it meant, had the chance to develop the questions and concerns that they had, to help them to develop an agenda that was around their interests in this, and then had support within the consultation to identify what the next step might be? How would that be? Because it would look much more like buying a mobile phone, actually. And if you put that into the context of the whole system of long-term conditions care, and some of you may have seen diagrams like this before because the Department of Health NHS England has adopted this as the house of care. It looks a bit like thinking about what are all the pieces that need to be in place, what are all the bricks that need to be in place for truly collaborative care planning or shared decision making to take place in the middle. So we need to think about what is required for the patient first of all, because they're the person who's going to be affected by this. Of course, we're in an educational meeting, so we've thought lots and lots already about what needs to be on the right-hand side of this. And there's some brilliant stuff that I've heard this morning. I just love the human factors stuff because it gets to the heart of so much that we need to do. But then we find that there are all sorts of bits that come out of it. There's organisational stuff that needs to get right, depending on where you are and what's already in place. We've called that, for the sake of it, within the year of care setting, we've called that the roof. And then there's the business of commissioning and understanding what else is out there in the community, and we call that the foundation. So we've ended up with a house which protects and supports the process that's going on in the middle. The process is critical, but the support needs to be there. So when we've been working with individual specialties in the college, we've got those specialties to build their house. So what for gastroenterology do patients need for all of this to work better? What do I need within my gastro team to work better with my non-medical colleagues if I'm a gastroenterologist, or to work better with my medical colleagues if I'm not a gastroenterologist? How does the organisation buy into this? How do we make sure that people have the right skills, attitudes, and philosophy? So what can you, I'll try and take HEKSS out before we get it published on the website, if that's okay with you, but what can we as educationists do? And I think that's the question that I think that David was going to pose to me if we'd ever talked about this sufficiently. And I think it comes down to developing a core set of skills and tools, but underpinning those skills, we all know about people who are technically brilliant. I worked for years with a neurosurgeon in New Zealand. He was probably the only neurosurgeon I would have allowed inside my head. Fantastic, actually. But I'm an endocrinologist, and we don't send people to neurosurgeons for very much. We send people to neurosurgeons for pituitary tumours, which are the lowest risk surgery that they do. And he used to go up to them. He came from Egypt, so he had a nice thick accent. He'd say, "Tomorrow I am going to do brain surgery on you." And so my job the night before the surgery was to go round to the patient and say, Mr. Professor, whatever his name is, has seen you, and they'd say yes, and they'd look absolutely terrified and say, "What did he say to you?" And they'd say, "I'm going to do brain surgery on you." And my job was to say, "You know, it's not quite like that. Actually, let me just draw some diagrams and show you what's going to happen. And actually, the chances of anything really terrible occurring are very small, and we know how to manage them. And this is how we're going to do it." Now, I'm not setting myself up as being brilliant at this. It was just something I knew needed to happen. So Sam is his name. Sam, in a sense, had the technical skill, but there was something missing in the way that he worked with patients. So we need to develop. I love him. He's an amazing guy, actually. Just if you've ever done those colour things, you know, colour personality things, very red. Okay, very red. So we had a way of working that we understood, and he knew what I would do, and I knew what he would do, and it worked brilliantly, I think. But I left. I've got to dig deeper here, haven't I? Anyway, we need to develop the attitudes as well as the skills, because people can apply the skills, but if the attitude towards patients is not good, and it's not a partnership-orientated attitude, understanding that it's their illness, that they're the people who are the biggest stakeholders in the outcome of this, they have an interest in it, we need to allow them to voice that, then we aren't going to get this right. We do need techniques, we do need consultation skills, and some of those skills are new to us. And we need tools to support patients before, after, and during consultations. So there's a lot of work to do on all of that. And so what that means within training is implementing a skill set, but it needs to be woven in, and whether that's physicians or other health professionals, and one of our dilemmas is really we need to do this with teams, not with uni-professional groups. I completely take that. Having said that, my badge is Royal College of Physicians, so we start there. I'm sorry. But it is important, but we need to get that into the teams, undergraduate, postgraduate, and as people who are now practicing as consultants. For myself, I kind of keep telling the juniors that getting to being a consultant, I know it feels like the place that you're going to get to, but you're going to find the Himalayas are taller than that. And then I think there is this really key thing that fits really well with the sim stuff and and the human factor stuff that we've been talking about. People need to learn by seeing stuff and by doing it. And they need to, therefore, to be seeing it and doing it in other people as well. As we all grew up as learners, we admired particular people. We've emulated them. Sometimes they were good role models and sometimes they weren't so good. But we do need to develop that championship working. So, how am I doing? I'm over time. I'm not over time. Actually, I'm okay. I'm just gonna leave the last word with a wonderful GP from the southwest of England called Donal.
I'm Donal Hines. I'm a GP in Bridgewater in Somerset. This facet of the year of care, we're doing two amazing things that we've never really done before. The first one is we're actually asking patients what they want. We're very good at telling them what they want. You want to stop smoking, you want to lose weight, but in this case we're actually asking people what they themselves want. And then the second most amazing thing is we give it to them. We actually respond. We're not saying, you don't want that. What you want is, we actually respond exactly to a patient's needs. So changing the priorities, asking people what is their priorities and putting those at the centre of care really does make a difference. Let me tell you about Bob. Bob is late 70s, really bad knee, osteoarthritis of the knee, degenerative knee, hobbling about, couldn't operate because of his chest, bad COPD. I think he had well-controlled atrial fibrillation as well, but mainly his chest. And indeed, in the past year, he had numerous emergency admissions into the hospital because of his chest. Now, we had spotted him as at high risk, and we had put in a good care package. He had access to a care manager. He had lots of information. He had an escalation plan with steroid and antibiotics. I think he was already on the pulmonary rehab scheme. All of it was very good, but it didn't seem to make a difference in stopping his emergency admissions in the hospital. So on a routine visit, I asked Bob, what's really important in your life right now, or things right now? And his response was, actually, they're not good, bloody bad, I think he said. But the thing that upset him most was not his chest, which I actually thought it was, but it was the fact that his wife, Mary, had been admitted to a care home some months previously with dementia. And he, being relatively housebound, didn't have access and couldn't go and visit her. So responding to that, which was his greatest perceived need, we arranged transport for him, I think it was 3 days a week in the afternoons, so that he could spend some time with her. Surprisingly, he had no further emergency admissions to hospital with his chest. He now felt able to manage all the exacerbations that were occurring for his chest. So, very strong message. Yeah, I'm a convert here. We have lots of cases like this and mounting evidence for it. Responding to a patient's individual needs actually produces outcomes. It really works.
Thank you. I'm done.
Thank you. We do actually have time for a couple of questions before lunch, so I think we've still got the roving microphones. There's just one behind you.
Gordon Caldwell here again. What do you think of the initiatives of people like Dr. Amir Hanan to give patients their own access to the GP records? And he tells tremendous stories of patients actively involved in their own care, coming so prepared to consultations, for example, with renal medicine, that they turn into really productive consultations.
Yeah, absolutely. The question, I mean, I'm about to set up a group along with the Royal College of Pathologists around patients' access to their own results, which makes us a bit anxious, I confess, or some of us. No, but the reality is that we just have to ask the simple question, whose results are they? They're not my results, they're their results. And all of the evidence that we have, and we have a lot of evidence now from the Year Care programme as well, is that the more patients know about their own health situation, the more likely you are to have helpful and useful joint consultations. And that combats one of the big anxieties that we have as healthcare professionals, which is all of this is going to take an awful lot of time. And I guess that little model I showed suggests that actually quite a lot of that time doesn't need to happen in the consultation. Patients have time. if we give them the opportunity, they have time and interest in looking at their own information, discovering what it means for them, and they'll have ideas. And our job then is simply to answer the questions and to steer and guide and provide the expert input, our expert input, to what is already halfway to being their plan.
No, I would agree. I've just this week had a patient, 2 months diagnosis, delayed diagnosis of an insulinoma because the results got lost in my office. If they'd gone direct to the patient, he could have said, here's my C-peptide insulin result, what's it mean?
Yeah. And I saw a lady yesterday in an antenatal diabetes clinic because she has thyroid disease, but that's where we see them. And she, 6 weeks ago, had rung up for her thyroid function results, and her GP said, I can't access them, which I don't believe is correct. I think they should be able to, because the system's now there for that to happen. So she rang the medical admission to the pregnancy assessment ward, and they said, I'm a clerical person, I can't tell you your results. And no one got back to her, and actually she needed a change in her treatment. And I felt bad, and she felt bad. And the only reassuring bit was the baby doesn't care at this point in her pregnancy. But that's not important, because she could have self-managed that perfectly adequately.
So it's a big change in medical culture, not in our patients' culture. I think we think it's all our care and it's their care, and they should have the information and access and bring it to us.
Patients love it. They don't need to be encouraged. They just do it, on the whole.
Can I just do?
How do you deal with those clients that are articulated enough to what they call that, to be involved in the decision making and to participate? And what happened to those people who are not articulate enough or do not feel sort of powerful enough to deal with this issue?
I think there are issues around vulnerable groups. There are unquestionably vulnerable groups. But fundamentally, the decision of the extent to which a patient wants to get involved is their decision. So for some patients, they may say, look, I really don't understand this, and I utterly trust you, and I just want you to make the decision. But they have to be allowed to decide that that's where they want to go. We have to do everything we can to encourage their involvement and engagement. So the onus is on us, because we're in the position of relative power to do that. And what we actually find is patients want to be much, much more involved than we ever imagined that they were going to be. Even vulnerable groups want to do something. And the NHS Confed produced a little short video thing called Choices that I was given 10 years ago, which was incredibly powerful about vulnerable and dependent people saying, but I always want choices about something. It might just not be about that. And that's important.
Yeah. I think we've got time for one more question. I think you've obviously preempted, David, so... So does anybody else want to ask another question? In which case, I'll thank you very much for a really interesting talk, and thank all of our speakers from this morning. We're going to break for lunch at 12:15, which is about just on time, and be back in this room. I think Kevin is going to do an introduction to the workshops. I think is that one. You've got your programs in front of you. Is it 1:15? Yeah. Okay. So enjoy lunch, and thank you very much for your attendance.